One. The recording is started, sir.
Good evening to all. So we are here for another masterclass. The topic for today is luteal support simplified. Luteal support is one aspect where there is a lot of variation in clinical practice and a lot of dilemma amongst clinicians. So what does evidence have to say? To throw more light on this, Dr. Abha ma'am decided to take up this topic for today. So over to you, ma'am.
Thank you, Bhavani, for opening up this lecture also. And luteal support simplified. We'll just go about this. Oh, it's going reverse. Okay. What are the questions we are going to answer in this talk today? What is luteal phase? What is the function of luteal phase? What is luteal phase deficiency? When does luteal phase deficiency happen? And situations in which luteal support is required. So on these 5 questions, we will frame the whole talk. And then simplifying individualized luteal support will be the last question which I would answer in this talk. Having said that, what is luteal phase? What was our first question? There is a follicular phase and a luteal phase, which is divided by ovulation, by happening of a ovulation. And this makes a menstrual cycle. Luteal phase is the period between ovulation and establishment of a pregnancy or starting of the next menses. Generally, luteal phase duration is about 12 to 15 days. What is the function of the luteal phase? This is our second question. You know, these are diagrams which we see always, that from the anterior pituitary, it is the FSH and LH, which rises just before ovulations with a small peak of FSH. Out of the ovarian hormones, estradiol, as it rises, progesterone is low at ovulation. The estrogen comes down and progesterone goes up. And on the menstrual cycle phase in the uterine endometrium, we know that first there is proliferation and of the endometrium, and then once ovulation has happened, under the effect of corpus luteal progesterone, there is compaction of the endometrium. It doesn't grow any further like it was growing in the follicular phase. It becomes compacted to a certain thickness, and that is when recruitment of new follicles for the next cycle start in absence of a pregnancy. So luteal phase aims at creating a window of implantation to successfully cause implantation of the embryo. The whole purpose of endometrial growth and receptivity is all targeted towards this one ultimate function. Progesterone is the most important regulator or orchestrator of the luteal phase. So it is just progesterone, progesterone, progesterone. So what is luteal phase deficiency? It is defined as luteal phase not capable of implantation or maintenance of pregnancy. This was first described in 1949 by Georgina Seeger Jones. Georgina Jones is a very, very important name which we all always remember. And she said either there is defective progesterone synthesis by corpus luteum, or the receptor laying down is poorer, and hence the progesterone can't work on that, resulting in infertility or early pregnancy miscarriage. When does luteal phase deficiency happen? This is the fourth question. Well, it can happen in an absolutely natural ovulatory cycle, and it has been observed that 3 to 20% of infertile women could have cycles which show LPD. And women who have recurrent pregnancy losses, as much as 60% could show luteal phase deficiencies in natural cycle. Stimulated non-IVF cycles. When we say stimulated non-IVF cycles, then these are mildly stimulated cycles aiming at 1 or maximum 2 follicular growth. Now, here luteal phase defect may happen in 50% of cycles. 50%, which is a huge percentage. Then we come to stimulated IVF cycles using either GnRH agonist or antagonist, and luteal phase defect would happen in all cycles, all cycles, unless they are supported. And the last is frozen embryo transfer cycles on HRT. We'll have to make the luteal phase. there would be luteal phase deficiency. We do not support it. You put an embryo inside after giving estrogen, and if you don't support the luteal phase with a different hormone, it will happen in every cycle. Having said that, let us talk about luteal phase defects in stimulated cycles, because in non-stimulated cycles, we only can know the incidence, and in stimulated cycles, we can know the incidence. But what happens in stimulation cycles, like clomiphene citrate? Clomiphene citrate can treat luteal phase deficiency and it can create luteal phase deficiency, both. Why is it so? Because the estradiol levels go quite high. One of my DNB students had done a study on this, clomiphene versus natural cycle. And we found, Dr. Rachna Verma had done it long, long ago. And we found that estradiol levels were at least 50 to 80 um, picograms higher than what it was in a natural cycle when we gave clomiphene. So the estrogen levels go high, and therefore the luteal E2 levels are also high. The stromal glandular asynchrony starts happening because the stroma grows by E2, glands grow by progesterone. Anti-estrogenic effect also is there of clomiphene. So one of its isomers sits on the estrogen receptors, and hence estrogen can't act on them, even though serum levels are higher. But some of the estrogen receptors have been blocked due to the anti-estrogen isomer of clomiphene. And estrogen receptors are therefore downregulated, which means that less estrogen receptors are available for high E2 levels to act. And because of this, the progesterone receptor laying down is a occurrence of estrogen receptor upregulation. When they are downregulated, then progesterone receptors are also low. In letrozole, what happens? There is low estrogen levels in follicular phase. Sometimes ovulation happens at estrogen levels of 60 picograms only. And hence, the progesterone receptors also may be low in the luteal phase. So these drugs do change the estrogen-progesterone ratio, and hence the luteal phase may become less supported. Then we come to gonadotropins and endometrial. Gonadotropins, what happens? It can lead to very high E2 levels. And once the E2 levels go up, we all have seen on the day of HCG, the progesterone levels also might be higher. Once the progesterone rises, there is a glandular stromal dyssynchrony. And if there are more than 2 follicles and we do not give anything after stimulation with gonadotropin, then we would find that luteolysis has started happening, because the LH surge which happened could not support more than 1 or 2 follicles in totality. And when we use IVF with agonist and antagonist, we've already suppressed the pituitary. Antagonist may suppress it for a short while, agonist for a longer while. But the pituitary gonadotropins are blocked. We don't have any gonadotropin coming from the pituitary. And we all understand a little bit of LH is important during the peri-implantation period. And if the pituitary is blocked, till the embryo starts secreting its own HCG, it is the pituitary LH which supports the process of implantation. That is on maybe day 5, day 6, day 7. And once implantation happens and the connection of the embryo with the endometrial blood vessels happen, then it is the beta HCG which starts rising from day 8 onwards. And another problem is that there could be very high estrogen levels, and therefore the estrogen progesterone ratio could be altered. There could be lysis of multiple corpus luteal, and there is increased cytokines which can destroy the endometrium. So luteal phase defects in all stimulated cycles can happen, but on the other hand, these drugs are also capable of correcting a deficient luteal phase which has happened in the natural cycle by taking the estrogen levels higher, by upregulating the E2 receptors. Letrozole, clomiphene takes higher estrogen levels. Tissue paper de dena mujhe. And gonadotropin might also do this if there are more than 2 follicles, because luteolysis will happen. Close this door. So can the trigger also cause LPD? Trigger is the final release of LH surge, or something which simulates LH surge? Yes, trigger for final oocyte maturation in a controlled ovarian stimulation cycle for IVF decides the occurrence of LPD. And you all know it so well that if we induce a LH surge of the pituitary by any drug like GnRH agonist, then we might get LPD again. Why? Because the LH surge is not sustained enough till day 6 or 7 of the luteal phase, so that, it is not sustained enough to support the endometrium, and two, the lysis happens very fast. So HCG leads to least luteal phase deficiency. GnRH agonist trigger leads to profound LPD. No trigger, extreme or complete LPD. If you don't give a trigger, then the LH also will release on its own terms and conditions, and LH levels may not be very high, and hence there would be complete LPD. This database systematic review of Cochrane in 2014 shows that if we give a GnRH agonist versus HCG trigger for oocyte maturing, favors GnRH agonist in OHSS incidence. So OHSS doesn't happen with GnRH agonist, but okay, but with HCG trigger, OHSS would happen. But luteal phase is absolutely unsupported by GnRH agonist trigger, whereas it is very well supported by HCG trigger. So it is for us to balance whether we should go for GnRH agonist trigger or we want to go in for, if we give a GnRH agonist trigger, we often feel, no, we will not do embryo transfer because the luteal phase is going to be very defective. But if we give a HCG trigger, then we know luteal phase is going to be taken care of, but there could be OHSS early as well as late. So this is a very beautiful diagram, which I like a lot. It could be confusing when you give GnRH agonist, that goes away in 20 hours, but it induces a natural LH surge, which stays there for 36 to 48 hours. And if you give, GnRH agonist would trigger the natural LH surge. If you give HCG, then it stays for day 6 and a little beyond also, at the time when the embryo is already implanting into the endometrium and will start secreting HCG within a day only. So this is a small gap period, day 6 to day 8, or I would say day 5 to day 8, in which the embryo is implanting. The HCG is supporting till almost day 6, day 7. And whatever is happening on the pituitary level, the LH coming from there is also supporting. And if more LH comes, it will support better till day 8, when adhesion has happened and the embryo is now connected to the vascular system of the mother, secreting beta HCG to further support the implantation in a cycle. So this is a very, very nice picture, which I like, that HCG support is there till day 6 or 7. And that is the time when the embryo is trying to find its place on the endometrium and secrete HCG within a day or two. So the lacuna is only over here a little bit, which we have drugs to support it. So what is an abnormal luteal phase? HCG, day 6, it acts till day 6. And this is LH activity deficient period, where the embryo, if implants, will start secreting HCG. GnRH agonist has a long LH activity deficient period, and the embryo implantation is far away. So this is the period which needs to be supported. And if we do not support this period, this embryo will not implant. So having said that, we come to a little more statistics. HCG shows a delivery rate per patient when it is given is like 31%. This is old data, but when we give GnRH agonist, the pregnancy rate is 6, like 3 out of 55 got pregnant. And early pregnancy loss rate is very high when we give GnRH agonist, vis-a-vis when we give HCG, the early pregnancy loss rate is only 17. Having said that, what decides the luteal support? How do you decide what luteal support you're going to give? Extent to which ovary is stimulated by controlled ovarian stimulation. So this has become the most important factor today, where you decide what luteal support are you going to give. Are you really going to implant the embryo in that cycle only, or you are going to wait for the for another cycle to put the embryo inside. So if the woman is normally stimulated or hyperstimulated, these are two conditions which will make you decide what luteal support are you going to give. Another one is agonist or antagonist protocol use. So once you're just doing ovarian stimulation for maybe IUI or just for ovulation induction, then also you need to know whether your ovary is hyperstimulated or normally stimulated. Say you're doing ovulation induction in a hyperresponder oligoovulatory patient, you will have to decide. Agonist antagonist protocol, HCG can be used with both the analogs, that means agonist antagonist, whereas agonist can only be used within an antagonist cycle. And the trigger for ovulation before OCR can be HCG or agonist. So we have two drugs to trigger ovulation before egg retrieval in a IVF cycle. Situations requiring individualized luteal support in IVF. Cycles with conventional controlled ovarian stimulation with agonist or antagonist protocol all require luteal support. All controlled ovarian stimulation antagonist IVF cycles with agonist trigger will also require luteal support. All frozen embryo transfer cycles using HRT for endometrial preparation, which means estrogen for endometrial preparation, will require luteal support. So all IVF cycles with conventional controlled ovarian stimulation with agonist or antagonist protocol undergoing fresh embryo transfer, what are you going to do? So you've done controlled ovarian stimulation, there is hyper response. What will you give? You may give progesterone only or combine with estrogen 2 milligrams twice a day for full luteal phase. COS normal response, you would give progesterone or combine HCG, also 3 doses in the first week of luteal phase. So this is what we were doing when we were giving agonist protocols. And the third one is normal response, progesterone, or you can even combine agonist mid-luteal 1 to 3 doses. Now, if you saw with HCG also, there was a small gap, day 6 to day 8, when the HCG support starts finishing off and the HCG production would start if the embryo is trying to implant. At that time, agonist mid-luteal will release whatever LH is there in the pituitary, and that could also act as a support. So progesterone is universal. For normal response, for hyper response, you're giving progesterone. Either you combine progesterone with a small dose of estrogen or nothing at all. Especially in hyper response, we like to give small doses of estrogen because estrogen falls very rapidly in the luteal phase. And a hyper responsive patient will have very high levels in the follicular phase. So it has been seen that giving a small dose of estrogen supports the endometrium a little better. Whereas if there is normal response, you can combine progesterone with either HCG, day 1, 3, and 7, or day 0, 0, 3, and 6, and 1, 4, and 7. That's how we used to give HCG, and the dose used to be 1500 units, which is almost not seen in today's cycles. You don't see us giving HCG anymore because OHSS is the biggest threat to these young women, which we want to avoid in all cases. But a mid-luteal agonist can be given in normally stimulated cycles. If they are hyperstimulated cycles, again, mid-luteal agonist can lead to OHSS-like picture, and we don't like to use it. So all controlled ovarian stimulation, IVF antagonist cycles with agonist trigger and fresh ET to be done. Now, profound luteolysis happens. This I go on telling everyone after GnRH agonist triggering because the effect is gone in 48 hours and the embryo is yet to arrive on the endometrium, and by that time corpus luteum lysis starts, the cytokines are released which start destroying the endometrium. So we need to give aggressive luteal support to secure reproductive outcome. And what does this consist of? It, in addition to estrogen, progesterone, which I was talking about, a small bolus of HCG is important. It can be given on the day of OPU, or it can be given 1 day later, or it can be given in 3 divided doses of 500 on the day of OPU, 500 next day, and 500. So within 48 hours, we've given small boluses of HCG, which will support all the corpus luteum through 6 or 7 days when the embryo implantation happens. Progesterone, we always like to start the day after OPU for 14 days. We never start it on the day of OPU, ovum pickup. We like to start it on the night of the second day, or sometimes we even skip the second day and start it the morning. I mean, it is like we've done the OPU today, next day we give no progesterone. Next day in the morning, we can start progesterone, or in the night of the day next to OPU. Estradiol valeriate from day after OPU for 14 days. So estrogen, progesterone, both have to be given because corpus luteum is not going to support. It will support if you give a small bolus of HCG, but in a hyperstimulated cycle, it is, oh, and when you've given a GnRH agonist trigger, you know that you have stimulated the cycle more than what would keep her safe. So a small amount of estrogen is also very desired here, and that would lead to a nice live baby for us. Now comes frozen embryo transfer cycle using HRT for endometrial preparation. Estrogen is priming of endometrium to ensure that adequate proliferation has happened. So it doesn't matter how many days you give estrogen, what source you give. And let me tell you that ever since Dr. Nikita told me that they use vaginal estrogen, I have used it for a few patients and it really worked well. So estrogen priming of endometrium is given whether you use oral estradiol micronized, or you use dermal, or you use vaginal. Once you find that there's adequate proliferation and the endometrium has almost reached 1 millimeter, less than that on the day of oocyte pickup, then you start progesterone administration to create the window of implantation for embryo transfer. And when does the window of implantation form? It forms exactly around days after replacing progesterone. And you can give a small dose of estrogen if you want. I have stopped giving. I used to give it when I made this presentation maybe 5-6 years ago, that I used to use estrogen with progesterone for 14 days. And we would start estrogen also 24 to 48 hours after the ovum pickup. So what is the support in stimulated cycles? Progesterone. So progesterone is the Bible, or it is the Quran, or it is the Gita of luteal support. So progesterone is required whether it is a HRT cycle, it is a natural cycle for frozen transfer. There also we feel progesterone should not be less. You know, natural cycles also have LPD. So why let that 3 to 15% of LPD happen? Give little progesterone, there'll be no harm. It will only maybe prevent LPD from happening. So progesterone is the universal supporter. Estradiol can be combined with progesterone in hyperstimulated cycle where we want to do a fresh transfer, and it has to be combined in HRT cycles for frozen ET. So you have first built the endometrium on estrogen, started progesterone. At that time, physiologically, if you see, estradiol levels drop in a natural cycle. Here also, you can reduce the estradiol levels or reduce the dosage by 1 tablet to still support the endometrium very well. This reduction in dose keeps the balance between estrogen and progesterone very well. Then we can give small doses of HCG along with progesterone when there's normal response and we feel that a little HCG will take over the patient through the 7th or 8th day when it will start secreting its own HCG. Then if you give a GnRH agonist, then you can give P4 with GnRH agonist mid-luteal. This is a favorite regime of mine in IUI cycles where I stimulate my patients with gonadotropin, and I love to give them GnRH agonist on day 6, 7, and 8 because I feel that the HCG trigger I've given will wear off by day 5 or 6. And if I give a little agonist on day 6, 7, 8, it will stimulate the pituitary to bring in more LH to help implantation. And it can also be given in controlled ovarian stimulation with a normal response. So what, and the last is when you give a agonist trigger, then you have to add a small dose of HCG to your progesterone estrogen. So whether you give progesterone alone or you give progesterone with estrogen in a fresh transfer, if it is agonist trigger, add small amounts of HCG. If it is HCG trigger, you can just sit tight with giving only progesterone or a little estrogen with progesterone so that the estrogen levels don't drop very drastically in the luteal phase, especially if the patient is stimulated and has got very high follicular phase estrogen. So what are the advantages of progesterone compared to HCG? Corpus luteum can be rescued by HCG. HCG stimulates corpus luteum to produce progesterone. Estradiol both also produces placental protein 14, integrin alpha 5 beta 3, and relaxin to support the luteal phase. So, if we stimulate the corpus luteum, that is the best because it knows in what proportion it needs to stimulate estradiol, alpha 5 beta 3, integrin, placental protein 14, and relaxin, everything to support the luteal phase. But if you are not stimulating it like this, then you will have to give a little estradiol and small doses of HCG to allow the corpus luteum to produce all these. Disadvantage, we all know, risk of OHSS increases. And another point, we do not give HCG. The last dose should be at least 7 days before a pregnancy test, as it may interfere with pregnancy detection and give us a false positive beta HCG. Progesterone with estrogen is to be given in agonadal cycles, which means that when you are not making a corpus luteum, like frozen embryo transfer cycles, they could be for ovulating patients and they could be for patients with premature ovarian failure, but you give them estrogen and then you supplement with progesterone, but you continue a small amount of estrogen here also. And this is in absence of a corpus luteum. In hyperstimulated cycles, they do better with 2 to 4 milligram estrogen along with progesterone as luteal support. And this was the thought which we always went with. However, now we have stopped doing embryo transfers in hyperstimulated cycles. Earlier, when we were using a long agonist protocol, we mostly did fresh transfers, less of frozen transfers because we had slow freezing methods and the results were not so good. Now with vitrification, any cycle which is hyperstimulated, we don't do a transfer. We just let the cycle dissolve and then do a transfer in either a natural cycle or a HRT cycle subsequently. And aggressive, I've already told you, I want everyone to remember that with GnRH agonist, the support is aggressive luteal support. It doesn't consist of only progesterone and estrogen like a frozen embryo transfer cycle where we do not make a corpus luteum. It also has a small dose of HCG. Why? To prevent the corpus luteum from breaking down and releasing cytokines, which will destroy the endometrium despite the estrogen progesterone which we are giving her. Having said that, agonist, this was a novel method. One of my FNB students, Datta Prasad, did a study on this. And the thought behind it is that GnRH agonist small doses, 1 milligram, stimulates pituitary gonadotropes to produce more LH, which directly acts on endometrium by locally expressed GnRH receptors. It may also act on the embryo with doubtful adverse effects. We don't know. The dose is 1 milligram a day, Lupride for 2 to 3 days from day 5 or 6 of OCR. And it is mainly only effective mostly in antagonist-treated gonadotropin-stimulated cycles. However, I've brought in this, which is the study which motivated me to do the study. And this was like 6 relevant RCTs were identified, including a total of 2012 patients. And it was seen that GnRH agonist addition during the luteal phase significantly increases the probability of live births. And here he found subgroup analysis according to the type of GnRH analog used, whether it is agonist or antagonist. It did not change the effect observed. But then we did our own study. This is my study with Datta Prasad Imamdar, which said that 3 1 milligram doses of Lupride administration 6 days after oocyte retrieval in the long protocol cycles did not result in an increase in ongoing pregnancy rates. Well, I found it did not increase. But then on the other hand, I love to use it in my IUI cycles where I've not suppressed the LH of the pituitary like in a long agonist. And I do find the results much better. So what is a wonder drug in luteal support? Progesterone is the wonder drug in luteal support. And what is the journey of progesterone for use in luteal phase and pregnancy? Well, we started with injection proluton depot in the early 1930s, and then estranes, pregnanes, guananes all came up. Then came up another drug, which is used even today, which is dihydrogesterone, and which is a retroprogesterone. Like if you see the structure of a micronized progesterone, if you reverse it, it becomes dihydrogesterone. And then came in the prometrium or utrogeston in the 1980s and 1998, which is pure micronized progesterone. So what are the drugs we are using? One is retroprogesterone, the micronized progesterone, which is identical to the natural progesterone. And we are still using the drug which was invented in the 1930s, 17-hydroxyprogesterone, marketed by the name of Proleton depot. One word about dihydrogesterone. It is a synthetic isomer of progesterone and it is the only progestogen used in luteal phase or pregnancy. Why is it so? Because of to natural P4 immunomodulator. Progesterone is the greatest immunomodulator and the only synthetic isomer, the only progestogen which is also immunomodulator is dihydrogesterone. It can be absorbed orally. It's a stable molecule made by conversion with ultraviolet light. Dose is 20 to 30 milligram a day, 3 divided doses. It has 50% higher affinity to progesterone receptors than progesterone itself, and it does not show as progesterone in blood bioassay. So we do not know whether it's working or not because the progesterone levels don't change. So we get to know the real progesterone levels by whatever the patient is making from her corpus luteum. But what dihydrogesterone is doing, we do not have a blood assay to tell that. It is available widely in Europe, UK, Australia, Hong Kong, India. It was previously marketed in USA, but now no longer available over there because their food felt that this should not be registered on. One word about this. This study evaluated combination of two processes which have synergistic effects to influence absorption of progesterone orally. Normally, progesterone is not a stable compound and we cannot take it orally. Or, I mean, if we take it, it is very unstable. So what they had to do, they did micronization. And what is micronization? It refers to small particle size of the progesterone, which is less than 10 micron, because this is better absorbed. 1 micron is equal to 0.001 millimeter, and it has been suspended in long chain fatty acids. So on the basis of the results of this study, the optimal preparation for administration of natural progesterone should include micronization of the progesterone particles. That means make them very, very small particle size, and dissolution in oils consisting of principally long chain fatty acids. So oral tablets were made 100 to 400 milligram, and they were used as 3 times or 4 times. But there is extreme variability in serum concentrations. Why is it so? Due to individual gastric filling and enterohepatic circulation with too many side effects. So it is absorbed through the stomach, goes to the liver, and any steroid, whether it is estrogen or corticosteroid or progesterone, which goes to the liver, will have very differential effects on the blood levels when it's circulating. So this went into disrepute. Then the intramuscular injection, it is once a day in sesame oil and 10% weight by volume benzyl alcohol as preservative. Warming the oil solution decreases its viscosity and may reduce pain. So as always thought, instead of a cold pack, giving a warm pack might reduce the pain of the intramuscular injection. So this also went into disrepute because it was so painful. The vaginal soft gel capsules, 200 to 400, used twice, absorbed by the first uterine pass effect, has 10 times higher concentration in the uterus compared to serum. So if serum shows a 10 nanogram level, the uterus will have a 100 nanogram level. How does it go to the uterus? Direct diffusion cell to cell, lymphatics from the vagina to the uterus, vein to artery portal system, which is there. So another is vaginal soft gel capsules, and there is a vaginal gel also, which is 90 milligram, 8% oil in water emulsion in polycarbophil base, which ensures that the gel adheres to the vaginal epithelium, while the emulsion provides oily depot to release progesterone into aqueous phase and into the tissue. So once it gets stuck to the whole wall, then the progesterone is released into the aqueous phase and then into the tissue. And these two have been the cornerstone of the progesterone being used all over the world. So now oral micronized progesterone slow release have been brought into the market, and there are different methods used to optimize oral use, because a lot of doctors and patients both did not want to use the vaginal route. This allows smooth, slow release of progesterone from intestine over 24 hours, offering a once-a-day convenience, avoids sudden drug release or dose dumping, thus loss of drug due to hepatic metabolism, and minimizes dose-related central side effects, including drowsiness, because it's taken once in the night. So these drugs have been brought into oral use, but still clinicians are not so comfortable using them. At least I am not very comfortable using them. The oral NMP slow release or the dual release tablet, which comes by the name of oral microgest. Having said that, role of progesterone in luteal phase is prostaglandin synthesis, which quietens the uterus, increases the level of CD blocking antibodies, relaxes uterine musculature. It suppresses inflammatory cascade. So it is anti-inflammatory. This is the very important role of progesterone, being anti-inflammatory, prevents alloimmunity and rejection of the embryo, and increases PIBF, progesterone-induced blocking factor. So having said that, take-home message is progesterone appears to be universally effective in ovulatory as well as non-ovulatory cycles for luteal support. So whether you have made the patient ovulate and then you use progesterone, or you don't make her ovulate, just for frozen embryo transfer, you are inducing progesterone is the hormone which will make the endometrium and the window of implantation for the patient. Vaginal progesterone appears most effective route for progesterone administration. Dydrogesterone appears promising if oral drug is desired. HCG only in mild to moderately stimulated cycles because of the risk of OHSS. It has no role in non-ovulatory frozen and embryo transfer cycles. Please, I beg of you, don't use it when you've not made a corpus luteum. I see nth number of prescriptions using HCG in patients who have gone HRT embryo transfer cycles. Combination of HCG with progesterone is more beneficial in terms of pregnancy rate. So HCG is good with progesterone, but then combination of estradiol and progesterone appears to favor pregnancy rate in hyperstimulated COS cycles. And the last is GnRH agonist for 1 to 3 days in luteal phase appears to be effective luteal support in antagonist cycles. So antagonist cycles, or no agonist, no antagonist cycles also. After GnRH agonist trigger, a bolus of small HCG dose on the day of OCR or 1 day later is very essential, along with estradiol and progesterone support throughout the luteal phase. So the real voyage of discovery consists not only in seeking new landscapes, but in having new eyes for already what is there. Rediscovery of progesterone activities plays the hormone in a key role in reproductive medicine, and especially also in prevention of preterm labor apart from luteal support. Thank you very much. Oh, this is my study, which never got published, where I used in IUI cycles, and I saw a pregnancy rate of 22% versus 6.8 when I used GnRH agonist with progesterone and HCG with progesterone in my IUI cycles. IVF cycles, Datta and I did a study and we saw no difference when we gave agonist with progesterone. So this was just a last slide, which I had not presented because the presentation was becoming too long. Thank you very much for listening to me. And now we can start chatting. This is the part of this masterclass which I love most.
Ma'am, thank you so much for this comprehensive lecture. Dr. Sophia wants to know, do you use agonist for luteal support even in FET cycles?
No, if FET cycles, well, if it is a natural cycle, then I would only add a little progesterone. And if the FET cycle is a HRT cycle, I would never use agonist. Only if I mean, if it is a stimulated cycle, I might think of using a luteal agonist on day 6, 7, and 8, but I don't really. I try to reduce the number of drugs which I give to patient. I feel very proud if my prescription carries only 1 or 2 medicines in the luteal phase.
In HRT cycle, there is no corpus luteum, so no point of using agonist or HCG.
Yeah, no point of using agonist. See, agonist is not for corpus luteum, Bhavani here. It is for the LH from the pituitary. So
That
Sophia's
will,
question was quite logical to ask that do you want a little LH to come from the pituitary to help the embryo implant? I've never tried using
and
it.
that LH will ultimately help in releasing progesterone from the corpus luteum since the corpus luteum is not there.
No, the mode of action is 3.
Okay.
You are right about the corpus luteum is not there. It has a direct endometrial, embryo, and corpus luteal effect. So
Okay.
one will have to do a study to say, because I looked into studies and Tazaric became the main person who's done about 4 or 5 studies on the same topic. And he said it benefits most of his, but then in the same time, some studies said it does not, as did ours, where we give agonist long protocol. But in my IUI cycles where I did not use any agonist or antagonist, it appeared to help.
Okay, ma'am. Ma'am, Dr. Sharda wants to know, as agonist trigger, we are giving to prevent OHSS, but for support, if we give HCG as a support, doesn't it increase the risk of OHSS?
Definitely, Sharda, it will. Agonist trigger you've given because you've thought that you don't want to do a fresh transfer. So if you are sort of compelled to do a fresh transfer because you don't have embryos, because you have an embryo which is not worth freezing, you don't want to throw it away and you want to transfer it, that is when you will give a small dose of HCG, maybe 1000 or 1500, just to prevent the lysis of the corpus luteum. It will increase the risk of OHSS undoubtedly. So best is not to transfer when you've given a GnRH agonist trigger.
Dr. Sushma wants to know, do we always need to combine dydrogesterone with micronized progesterone?
Never. I do not ever combine it, only in cases where I'm having RIF and I feel the progesterone levels, micronized progesterone is less. And RIF now has gone to an extent where they have started looking at progesterone levels also. The latest what is it? Was it ESHRI or RCOG 2023 evidence which came in February said that you need to look at was it FIGO? Bhavani, what was it? Which said that you also need to look at progesterone levels. You again have to review and see the endometrial
Estrogen.
ESHRE. So the ESHRE guidelines said that look at progesterone levels also. And with dydrogesterone, I don't know what will happen to progesterone levels because it doesn't reflect in blood. So to give you that confidence that progesterone has gone up, it is better to give a injectable method if you feel that you need to give extra source of progesterone because the vaginal is not enough. But yes, when a patient is not able to take the injection, is allergic to it, or vaginal is not giving you adequate levels, one can combine dydrogesterone. I'm not too fond of it because it doesn't give me the confidence that the progesterone levels have gone up.
Another question is, what luteal support for dual trigger do you give in case you are planning a fresh transfer?
Just progesterone alone should be good. Why have you given the dual trigger? Is the patient a poor responder? Because in high responders, you will give GnRH agonist. In normal responders, HCG is good. Suppose she's made poor embryos. Suppose the fertilization was poor, and that's why you've given a dual trigger. And you do want to do a fresh transfer, you will give progesterone. You can add a small amount of estrogen if pre-trigger estrogen levels were high, more than 1200 or 1500. A small amount of estrogen can be added in the luteal phase, which was a usual practice with the agonist long protocol. But now with antagonist protocol, we've sort of dropped that practice of adding estradiol. Could you hear me, Bhavani? Hello?
I'm sorry, I just lost the connection.
Okay.
Dr. Sunita wants to ask, what do you use for luteal support in FET cycles? What all drugs and in what dosage?
You tell, Bhavani, you are working with me. What do we use for luteal support in FET, HRT cycles and non-HRT ovulatory cycles?
In HRT cycles, we are using only vaginal micronized progesterone and in a dosage of 400 milligrams twice daily, or using vaginal gel 90 milligrams twice daily, along with the estrogen. Estrogen is continued. And in case of natural cycle FET or stimulated cycle FET, we are using either vaginal micronized progesterone in a dosage of 200 milligram twice daily, or vaginal gel 90 milligram once daily.
Once daily, exactly. So Sunita, this is our luteal support. Folic acid may be an addition, that is all. So HRT cycles, you have 3 drugs, estrogen, progesterone, and folic acid. In natural cycles or stimulated cycles where you've let ovulation happen, only progesterone with folic acid is used. And the dose of progesterone is much lower in a natural cycle, 200 milligrams twice a day or gel once only.
Ma'am, Dr.
Nisha, what about LPS? Progesterone. And if your estrogen levels were very high, yeah? What did you say, Bhavani?
No, ma'am, nothing, ma'am. You can take up that question, ma'am.
Okay. Anyone else wants to? Well, what I do in LPS and dual trigger, even Tejashree knows it. Tejashree, you tell us what do we do in dual trigger given and we want to do a fresh transfer. Is Tejashree there? Bhavani, what do we do? Anything different if we've given dual
Nothing
trigger?
different.
Nothing
Nothing. It's
different.
just like HCG trigger, same, just progesterone we give if we are planning.
Only progesterone, no, nothing else. It's progesterone and folic acid. And today I had 2 pregnancies positive in which we did an embryo transfer on the 20th of April. And one was a fresh cycle, and all she was taking is a folic acid and gel. And gel was only once a day, and that is all I have continued her with for next 3 weeks to before she has the first scan for the embryo. So this is all we are giving. We don't give too many drugs. We don't scare the patient in the luteal space. Nisha, I call this luteal scare. Patients are not horrified by the injections they take for making eggs, but they are horrified by the luteal support which is given. And that luteal support shows your inner inconfidence, that you are so inconfident of the embryo quality that you feel your luteal support will overcome a poor embryo, which it will never do. So please don't support your patient with injectables and drugs. One source of progesterone is good enough. Suppose you are like sort of doing frozen embryo transfers and you find that you are losing out on pregnancies with very good embryos, you can look into the progesterone levels and increase the levels by whatever drug, one more source you think is good. It could be injectable or it could be oral dydrogesterone, whatever you trust more.
Dr. Gayatri wants to ask, is dual trigger better than HCG trigger in IUI cycles?
Why in IUI cycles do we need a dual trigger? Because in IUI cycles, along with HCG, maybe a LH surge will happen. I mean, you can go on increasing the drugs everywhere, but in IUI cycles, in any case, the pregnancy rates are around 20%. Why will we increase the drugs? People don't want to give gonadotropins to IUI patients. Why should we change the trigger? If you want to give a trigger, give HCG trigger. In any case, if a IUI cycle is overstimulated, you will cancel it. Only if there are 2 dominant follicles, you are going ahead with the trigger, and HCG trigger should be good enough.
Dr. Gitika wants to ask, what is the upper desirable level of serum progesterone on the day of frozen transfer?
Very difficult. Bhavani will answer this question. Her study, which has been published, is on this only, which is the level of progesterone on which, on the day of frozen embryo transfer, what levels of progesterone had the highest pregnancy rate and what was the lowest progesterone on which a live birth happened. Bhavani, answer this question.
The cutoff we found above which pregnancy rate was maximum was 8 nanograms. So there was no upper limit which we found in our study, though lower limit was 8 nanogram. Though we even had live birth with the serum progesterone of 1 nanogram. But on doing...
Not one, I think that was 2.6 nanogram.
yes, ma'am, I think.
I remember it was
Not 1,
2.6.
maybe 2 point, yes.
Yeah, because we did the study together, so I remember it was 2.6. And Gitika, let me tell you one thing. I have reported a case which you will go into literature and find that I started a stimulation on day 2 in a woman who was lactating for 1 year and did have amenorrheic periods, and we gave her Meprate withdrawal. On day 2, her endometrium was slightly thick, like 5.6, but progesterone was less than 1, estrogen was low. We started her stimulation. After 5 days, when we called her for ultrasound, we found that there was a small sac-like structure. So we did her beta HCG, and it was somewhere like, I think, 200, 300. And we went back on the sample, which was kept on day 2. On that day, it was like 500 or 600. We went back on the day 2 sample. It was somewhere around 200. We stopped all her stimulation. We gave her progesterone support from that day onwards. And this lady ended up with a live birth with a progesterone level of less than 1 when her beta HCG was 200 units. So, I really don't know how far. And then I searched literature when I was publishing this paper of mine. This was with Dr. Who was it?
Ruchi,
Who
Dr.
was that
Ruchi.
young, very enthusiastic observer?
Dr.
Ruchi.
Ruchi.
Excellent work. Doctor?
Ruchi. Dr.
Ruchi, yeah.
Ruchi.
She, searched the whole literature for me, and she found one Japanese study. She found one more study. She found 2 studies reported where progesterone levels were lower than 1. And during their IVF stimulation, they discovered that there was a small thickened endometrium sac-like structure, and they discovered that she was already pregnant with such low progesterone levels. So I don't know whether, progesterone level is a hype or it is a fact which needs to be supported.
And the other thing is that the cutoff varies depending upon the route of progesterone. So if you're using
Yes.
vaginal progesterone, the levels will be lower. If you're using intramuscular or subcutaneous, then the levels will be higher.
Yeah, but most of the studies say 10 nanogram
Yes,
is
for
enough.
vaginal, 8 to 10. Most studies say 8 to 10 nanogram.
Yeah. So that is the upper, that is a ideal limit of progesterone, Gitika. But the upper limit could go up to 40 nanograms also, and the lower limit could come down to 2.5 also, on which pregnancies happen and live births happen.
Dr.
In
Sunita.
extensive or aggressive LPS, all you do is you just give progesterone, the highest dose is 400 milligram twice vaginally of micronized progesterone. You can give a little estrogen also, and you give a small dose of HCG. So in aggressive LPS, you give estrogen, progesterone, and nano HCG.
Dr. Gayatri wants to ask, which is the best route of progesterone?
Yeah, anyone can answer who's worked with me.
You prefer micronized vaginal progesterone.
Yeah, and I think my whole team prefers, because our persistent pregnancy rate in FET cycles is over 60% with a single embryo transfer for the last, I think, 4 years or 5 years also. So we are doing single elective embryo transfer only. And Gitika has worked with me. She knows that we only use vaginal progesterone. We don't use oral or injectable. Injectable in some cases, when Sohani did her study, she took forward Dr. Bhavani's study to see that in cases where the progesterone levels were lower, giving an additional parental progesterone, will it increase the pregnancy rates? And she did show a small beneficial effect also. But still, I'm very reluctant to give injectables because if someone of you take an injectable, you know how difficult it is to take.
Dr. Sunita wants to know what is the maximum dose of estrogen you use during endometrial preparation during HRT FET cycle?
Sunita, I've learned from my own practice. First, I used to go up on oral doses, but now I've kept the oral dose to 6 milligram maximum. And what I increase is another source of estrogen because I know that if oral is not working at this dose, then there is some problem in absorption or the hepatic circulation is metabolizing most of it before it reaches the target endometrium. And so I like to combine uh, mm, uh, dermal estrogen. And after I had one of my master classes, and Nikita suggested to me that they use vaginal estrogen, I have a lot of times used the same progesterone valuate vaginally also and have got good results. So maximum dose is uh, 3 tablets of oral estrogen because they'll all go through liver. So I don't like to give more than 6 milligrams. And the dermal one, I'm happy to give even 2 applications 3 times a day because this doesn't go to the liver.
Dr. Naina wants to ask when should we consider to do individualized luteal support?
Yeah, this is when you're having recurrent implantation failures. Then you do all tests, and then ERA is another test, Alice, Emma. You find out where what is wrong, and if the window of implantation has shifted forwards or backwards, you do an individualized embryo transfer. You don't do an individualized luteal phase support. Individualized means depending on what stimulation regime you've used, if you're doing a fresh transfer. I've already given the whole summary of individualized, where you do fresh with a HCG trigger, you're doing fresh with a agonist trigger, you are doing a frozen in a HRT cycle, you're doing a frozen transfer in a natural or stimulated cycle. I've just shown you all the luteal phase support in my lecture today.
Dr. Sunita wants to know in fresh transfer, are you adding estrogen for luteal support?
I used to add once upon a time, Sunita, when we were using a lot of agonist long protocol, but nowadays I don't. In fact, any case which is stimulated a little more than normal, we don't do a fresh transfer. We just go for frozen transfer. So I don't add estrogen. Are we adding, Bhavani?
No, ma'am, we are not.
We are not
Unless and
adding.
until we are giving agonist trigger and doing a
Ah,
fresh transfer, we are not adding.
yeah.
Dr. Sharda wants to know what is the idea of giving luteal support in natural HRT cycle as corpus luteum is already there.
You are very right, Sharda. There is no need of giving it. Except what I showed in the beginning, that natural cycles also have 3 to 20% of LPD, luteal phase defects. So when we are transferring an embryo, we are always scared, and we know that giving a little progesterone will not harm, and hence we give it. It is only our fear which makes us um, uh, give progesterone. Otherwise, in a natural HRT cycle, you ideally don't need to give progesterone at all. You are absolutely right.
Dr. Shalini wants to know, do you routinely measure estradiol and progesterone levels after transfer?
After Bhavani's study, and when we get a RIF, then we measure it. Not estradiol, but progesterone, though many studies have come out on estradiol measurements also. But we don't do we do a estradiol measurement, Bhavani?
No,
No.
ma'am, no, we are
No.
not.
So we've seen progesterone only when we have RIF, then we start seeing it. Patient is going through a third transfer, fourth, and because we're doing single transfers, we have to be very careful that the patient doesn't get into that rut that, one after the other embryo transfer is failing. In those cases, I start measuring the progesterone and also give her support.
Dr. Naina wants to know, what do you prefer, aqueous or plain progesterone? Is aqueous non-inferior?
I don't know, Nena. You will all have to tell me because I still trust that the oil one was better, but aqueous is being used, and even aqueous is so painful because it has that little alcohol in it. And you couldn't hear the answer for dual trigger. If you give a dual trigger, you don't have to add anything extra in the luteal phase. Progesterone alone would do good because you've already given HCG and agonist both.
So Gayatri wants to know, is there any role of CoQ in endometrial preparation?
Not really. CoQ is a enzyme which helps mitochondrial function. So if a patient has low reserve, whether she's young or old, giving CoQ10 might improve her mitochondria and hence the oocyte conversion into embryo or the oocyte activation, whichever way. CoQ doesn't, according to me, I don't know whether it has any role in endometrial preparation. And please do not increase the prescription size of your patients. Don't scare them away because you're giving them so many medicines. Just give them the medicine which we know of will make the endometrium.
Dr. Ela wants to know if we have started progesterone for thin ET, should we continue it if patient conceives?
Estrogen for thin ET. No, if she conceives, then her placenta will start secreting everything. For thin ET, why have you started estrogen for thin ET and when have you started? Tell me, Ela. Ela, can you come alive? Can you unmute yourself?
Dr. Ela, can you clarify in which scenario are you using estrogen and thin ET? For FET or for
Pressure.
IVF?
I leave the question till I get a clarity about for what has she started. And if the patient conceives, you don't need to continue with estrogen. In fact, when we are giving HRT also, I reduce the dose of estrogen often when the patient conceives. And in fact, I also reduce it sometimes when I do embryo. I mean, when I give progesterone, I reduce the estrogen dose by 1 tablet. Sometimes I give the same dose also, but lately I found that the miscarriage rate had gone up for me, and hence I started reducing the estrogen dose after starting progesterone. Kush,
Again, we've discussed this. Do you check progesterone levels and consider any cutoff before transfer?
already discussed it.
Dr. Shalini wants to know, do you give estrogen as a luteal support in antagonist IVF cycle with HCG trigger?
I used to give, but I have stopped giving because I feel loading the patient with medicines doesn't help. I used to give once, especially in hyperstimulated antagonist cycles, because that was a model I followed with agonist long protocol. So I also continued it when I started antagonist, but I've given it up 7, 8 years ago.
Again, there are questions on progesterone measurement after FET and what cutoff and
Yeah,
what.
estrogenovas used for vaginal estrogen. Yes, I have learned it through the master classes from one of my clinicians who was once upon a time my student, and she gave me this idea, and I used it, and it worked very well.
Another question is, what is your opinion on routine use of LMWH for FAS?
No, no. No, never. It is only when it is RPL, and I cannot find the reason, or, it's a very, very precious pregnancy, just one embryo with great difficulty, then I would use it. But I do not recommend you all to use it. Even I would not want to use it, except in situations where I feel that nothing is working, do something, then I use it.
Dr. Gayatri wants to know, ma'am, what should be given additionally for a woman with RPL and high anti-TPO antibody?
I don't know really, Gayatri. These are questions which are so unanswered and they're so controversial. You have to find out what is the reason for RPL. And if you don't find a reason, then just take as seronegative, APLA positive. I mean, these patients could be with anti-TPO antibody, and you can still use low molecular weight heparin once the beta HCG is positive, because recurrent pregnancy loss is a very painful situation, and we really do not know answers when it comes out as unexplained recurrent pregnancy loss.
Ma'am, once you had talked about selenium, role of selenium in.
Yes, selenium is being used by endocrinologists, but I've seen it does nothing, and the books don't say that it has any role. So if anti-TPO antibody is there and the patient has RPL and her APLA screen is normal, her karyotype is normal, her endometrium is normal, I would still use low molecular weight heparin for her, considering that there are a subset of patients who are seronegative APLA positive. You have to read this chapter and you would know that there are certain complement fixation antibodies which are there in the blood, which are not picked up in the APLA screen.
Dr. Priya wants to know till what time do you continue estrogen and progesterone if the patient gets pregnant?
How much do we give? You tell us, Bhavani.
Estrogen, we stop usually once cardiac activity comes, we stop estrogen, and progesterone we continue till 10,
Almost 11, 12
week
weeks.
and 11 weeks we continue.
Sometimes we stop it at 10 weeks, but mostly we continue till the NT-NB scan, though it is too much of progesterone use. I agree that I'm abusing progesterone, but it's just my own insecurity which makes me use that once a day progesterone for the patient till the NT-NB scan.
Dr. Nisha wants to know, ma'am, can you repeat the
You
dosage
tell
of
us,
LPS?
Bhavani. Bhavani, you tell us, you've seen me using
We
it.
are using Leuprolide 1 milligram subcutaneously on day 6, 7, and 8 post ovulation. So during the
And
implantation.
if you go back on this lecture, you will see in a slide that it is day 6, 7, 8 when the embryo is gone, opposition, adhesion, and implantation. So at that time, probably a little support is needed because SCG trigger support is finishing off at that time. So it could help through that theory.
Dr. Gitika wants to know, do we need to give extra progesterone in females with endometriosis?
Gitika, you do a study and tell me. I need to know whether I need to give extra progesterone in females with endometriosis. I really don't know. What is everyone's opinion? What is your opinion, Bhavani? Is Tejashri here? What is her opinion? What is your opinion, Gitika? Unmute and tell me.
400 milligram twice daily, I feel is adequate dose. So.
As adequate dose. Very good, Gitika. I think what you're saying is right, and this is what I do.
Dr. Naina wants to know, do you prefer valerate or hemihydrate for endometriosis?
Well, there is, Naina, so much of controversy surrounding this. I'll tell you, in India, whichever drug becomes popular, like Progenova became so popular that maybe it was the number 3 drug prescribed by fertility specialists. And then came in an era where it's stopped becoming as effective. People who get Progenova from outside India, it's so effective. You give them 10 days and the endometrium blows up. Whereas the one you get in India, you've probably got a biosimilar with the same name and it is being sold under the name of Progenova, which probably the makers don't know of it and it doesn't work. So at that point of time, when we found that, Valerate is just not working, we changed over to hemihydrate. But now when I have to give vaginal, I go back to Valerate.
Dr. Gitika wants to know, should we continue same doses of estrogen after FET or can we decrease if we are using multiple routes?
Much better to decrease, Gitika. Please decrease and see your miscarriage rate will go down. It has gone down for me.
Dr. Priya wants to know, is there any role of prednisolone? When to give prednisolone in
No, I don't use, I've never used it in my life.
Dr. Ramesh wants to know, for blast transfer, we give 5 days of progesterone, but why only 3 days or 4 days if fresh transfer?
Huh?
You will
Because in a fresh
see
transfer, the corpus luteum is already making a lot of progesterone. So normally it is said that if you start supplementing with progesterone right after OCR, it becomes too much. It is better to give after 24 hours or 36 hours. So we start progesterone from the second day of OCR, sometimes even a little later. So you give it for 3 or 4 days, but if you will give it for 5 days only post oocyte pickup in a blastocyst transfer.
Dr. Gurbani wants to know, do you give immunoglobulins or intralipid or atosaban after
I've never used these and I don't know how to use them. Gurbani, I'll have to come to you to learn how to give them.
Dr. Sunita wants to know, are you adding any other drug apart from the routine drugs in case of RIF?
RF, I'm adding low molecular weight heparin with my estrogen, progesterone. I don't know. Rarely I have even thought of giving HCQs, but I really don't know if it has any effect. And I wouldn't advocate it on a forum like this that you use any of these drugs. What really helps is only repeat transfer when you don't find a pregnancy happening with 3 or 4 embryos. If you look into the new definition of RIF, you will find that it is very disheartening that we don't know the cause, but you have to try and put another embryo, and one of these embryos will implant.
Dr. Nisha wants to know, can triptorelin 0.1 mg be used as LPS instead of leuprolide 1 mg?
Yeah, absolutely. Absolutely. It is same, because if you give a Lupride trigger, you would use 1 milligrams. Lupride 1 milligram, it's not gram. And triptorelin is 10 times less, so it is 0.1 milligram. Okay, I think we've done enough. We've surpassed our time. We can't take up more questions. You can put your questions on the forum and we will definitely answer. And I would want anyone to answer, and you can give us evidence also for your answers. Thank you.
Thank you so much, ma'am. In spite of not being too well today, came for the class. Thank you so much.
Bhavani, I would want you to make an announcement that since I'm not in the country from next week, Wednesday onwards, I may not be able to take classes, and then we are conducting the FNB exam on 23rd, 24th, because 25th is election day. So
Okay.
till 26th, 27th, I will not be able to take a class. And everyone can give their topics of choice. Like, I took it on endocrinopathies. Now I took it on luteal phase because this was being sent to me. So you can send 1 or 2 choices and we can do classes on that again. Okay?
Thank you,
Thank you
ma'am.
so much, ma'am.
Okay. Thank you. Thank you.
Thank you.
Where is Dabe? I need to thank him.
Thank you, madam.
Today we went overboard. I'm sorry about it.
Madam, I
didn't
learned a
see
lot
the
of things.
time. I didn't see the time. I just saw it now.
Yes, ma'am. Thank you very much.
Thank you, the whole team of INTAS, for supporting this Zoom endeavor of ours on the Zoom platform.
Yes, ma'am. Thank you.
Thank you. Thank you, Bhavani, for
Thank you
being
so much, ma'am.
Now, next time you are going to answer all questions. I get tired speaking. Because you know the practices, and I want to absolutely give what we practice. I don't want to give a different answer from what we practice. And please understand, very few drugs are required if your embryo is good. You don't need steroids or IVIG or intralipids. Yes, RIF cases are different, but don't confuse a poorly made embryo and failure of IVF with RIF. RIF means top quality embryo and which has failed to implant. Thank you, everybody. Good night.
Good night, ma'am.
Good night.